My name is Huwaida Salim. I'm an assistant professor in the Department of Internal Medicine, University of Tennessee at Chattanooga. I really appreciate those who made the time to attend this live streaming early in the morning, and those who will be able to watch it or watch the recording in the future. In this busy time of all of us with COVID-19, I hope all of you guys to stay well and healthy. So today I'm presenting in this grand round about perioperative pulmonary complications and more. I have no financial or personal disclosure to share. So objectives of this grand round are we're going to be discussing impact of postoperative pulmonary complications, pathophysiology leading to these complications, pre- and perioperative pulmonary risk assessment tools and stratification, obstructive sleep apnea assessment, risk assessment tool and stratification, evidence behind preoperative diagnostic testing utility, evidence of protective lung ventilation strategies, and finally protocols and bundles to reduce occurrence. So postoperative pulmonary complications, including any complications affecting respiratory system after induction of anesthesia and after surgery. Incidence of PPCs in major surgeries can range from less than 1% to 23%. So several studies have shown that pulmonary complications to be more common than cardiac complications, but yet underappreciated. So why they are important? So mortality is increased in both the short and long term in patients who develop PPCs up to 30% in 30 days, compared with like 0.2 to 3% in those without it. So and can go as high as 24% in 90 days versus 1.2% without it. So it's also increased morbidity, and length of stay has shown to be prolonged by 13 to 17 days. So if the patient develop respiratory failure after surgery, required unplanned intubation, which usually happens within 72 hours of surgery, that will definitely increase, will be associated with increased morbidity, increased length of stay, increased ICU admissions, and of course increased hospital care costs. So especially in this increasing time of financial restrictions, maybe looking at this area of postoperative pulmonary complications as a potential source of cost reduction, it will be important. So here we have many postoperative pulmonary complications. I'm just listing here the most common one, but it's not limited to that, including respiratory failure, this is the most common complication. Respiratory infection, pulmonary or pleural effusion, atelectasis, pneumothorax, bronchospasm, chemical pneumonitis, pulmonary edema, and pulmonary embolism. So going to the basic about pathophysiological changes, this is very important changes happening during perioperative period, causing potential risks for developing complications. So changes to the respiratory system occur immediately after general anesthesia induction with suppression of both respiratory muscle function and central respiratory drive. So, and as a consequence of these changes, both lung volume and ventilation will be reduced, leading to the development of atelectasis, which occurs in 75% of patients, especially those who receive general anesthesia and neuromuscular blocking drugs. So changes happening to the respiratory system may take up to 6 weeks to return to its preoperative state after general anesthesia for major surgery. So atelectasis can, and this is, as we said, it's the most common complication. It happens in 75% of patients. Post-operatively, it can easily be seen on CT scan in the dependent areas of the lungs, irrespective of patient's position. For example, in image A, this is supine, and Brown in image B. So here we have a 68-year-old male with 50-pack year smoking history, COPD, hypertension, and diabetes mellitus type 2. He has been evaluated for coronary artery disease, status post-cardiac cath, plan for CABG during this admission. On exam, he is vitally stable. Rest of the exam within normal. His oxygen saturation, 95% at room air. So all his lab values within normal, including cell count, renal function test, and liver function test. So surgery team wants to know his post-operative pulmonary risk considering his major surgery. So now we're going to learn about pulmonary risk assessment. It does have 3 components, including general pulmonary risk, airway ventilation risk, and sleep apnea risk. So not a single assessment tool or process that can capture risks for all 3 components. So general pulmonary risk, it's divided into procedure-related and patient-related, and both of them subdivided into modifiable and non-modifiable risk factors. So there is many risk factors, so clinicians should be aware of non-modifiable and modifiable factors in order to recognize those at risk and to optimize their care. So procedure-related risk factors, as I said, it's subdivided into non-modifiable, including type of surgery, duration of surgery, emergency versus elective. Modifiable ones, those who we can play with, it's mechanical ventilation strategies, general anesthesia versus regional, neuromuscular blocking drugs. So certain types of surgery carry higher risk than others. Abdominal, thoracic, vascular surgeries have shown to have high risk of post-operative pulmonary complications. So upper abdomen laparotomy incision may have up to 15 times the risk of complications compared with lower abdomen. So surgical site is definitely the strongest predictor. The closer to the diaphragm or closer to airway, the higher the risk of complications. Same as the longer the duration of surgery, the higher the risk of complications. Emergency surgery compared with elective confers 2 to 6-fold increased risk of complications. So although type of surgery, as I said earlier, is non-modifiable, so laparoscopic it's non-modifiable by itself, but laparoscopic surgeries for both upper and lower GI procedures results in few PPCs than open ones. So now coming to patient-related risk factors. There have been many risk factors being identified and divided into non-modifiable and modifiable. Smoking and COPD can increase the risk of complications, but they are not as near as strong factors as having functional dependence, not being able to do ADLS independently, as well as age. So multiple studies have found that age more than 50 to 55 to be an important non-modifiable independent risk factor predicting for post-operative pulmonary complications development. So having long list of potential risk factors, it's great, but the most important and needed is to have a system to assess risks and stratify patients to do something about it. So that's why many prediction risk models have been published, but unfortunately, most of them have limitations, being highly specific either to surgical type or specific complications like respiratory failure or pneumonia. All of them, they lack inclusion of intraoperative risk factors, and most are not externally validated, and almost none of them capture data about obstructive sleep apnea. So that's why we have to assess for it separately. So looking at this table, this is basically the history of development of pulmonary risk indices. As you can see here, most of these tools focus on one pulmonary complication, so either respiratory failure or pneumonia. So that's why more and more authors suggest that AirSCAT, the one bolded in red, is the best tool we have right now, because it's the most inclusive of all postoperative pulmonary complications. So AirSCAT index, it's very easy to use, has 7 independent variables, including age, pre-op oxygen saturation, respiratory infection in past month, location of surgery, duration of surgery, emergency surgery, and pre-op hemoglobin. So it's a tally system. You don't need an online calculator, and most importantly, it's stratifying the patients into low, intermediate, and high risk, so we know which intervention we need to employ. So a newer trend we have seen in all pre-op evaluation, including pulmonary, is incorporation of intraoperative factors. So your risk assessment process is not static, it's dynamic. So in preoperative risk assessment, you may stratify a patient at low risk. However, that same patient develop desaturation, requiring more and more oxygen support to maintain, requiring pressors, or surgery took longer than anticipated, and this commonly may happen. Then we shouldn't consider this patient is still at low risk. So a number of tools are now incorporating those factors along with preoperative ones to reassess risk. The newer one we have from last year is SPORC-2. So it's basically assessing the risk of early reintubation within 72 hours of surgery, and SPORC-2 is recently validated, incorporating several different intraoperative factors, and that's adding to the pulmonary risk. So going back to our patient for his pulmonary risk assessment and stratification. So this patient, considering his risk factors, including non-modifiable ones, which are age, being a male and going for CABG surgery, and modifiable one, including smoking history, COPD, hypertension, and diabetes, and those shouldn't be a problem. We'll just optimally manage them and make the patient ready for surgery. But calculating his risk will go back to the AirSCAT index, putting his age, his pre-op oxygen saturation, which is 95, his location of surgery being thoracic, and duration of surgery. That will definitely put the patient at high risk of score more than 44, with postoperative pulmonary complication risk at almost 40%. So by this, I'm going to summarize the general risk assessment. So there is the risk estimate is less important than risk stratification to determine risk reduction intervention. AirSCAT is the most useful tool for preoperative pulmonary risk assessment, and optimal risk stratification should be actually adjusted on intraoperative factors to upgrade risk if patient required active ventilation management, desaturation or high FiO2 requirement, vasopressors administered, or surgery took longer than expected. So here in this table, again, I'm going to just mention some of the modifiable factors, but it's not limited to those. Basically, current smokers have increased risk of complications. Smoking cessation at least 4 weeks prior to surgery reduces risk, and we'll discuss smoking as a separate independent risk factor later. COPD and asthma should be optimally managed with inhaled bronchodilators or inhaled steroids, with systemic steroids if in acute exacerbation. So anemia, it's another factor. And per European guidelines, hemoglobin less than 10 grams per deciliter increases the risk of complications. So causes should be established and treated accordingly. For iron deficiency anemia, if we have the luxury of time, more than 4 weeks, so we can put them on oral iron supplement. If we don't have that time, so we can put this patient preoperatively on IV iron. B12 injection, EPO, all that we're trying to do is to avoid pre-op blood transfusion, which carries its own post-operative pulmonary complications risk. So obstructive sleep apnea, it's an important risk factor, which we'll discuss later as well. So basically, we optimize management by use of pre-op CPAP. And the same for the rest of comorbidities. Basically, the goal here is to optimize medical management. So smoking in 2014 meta-analysis of 107 cohort and case control studies have shown that smokers with more than 20 pack year history have higher incidence of post-operative pulmonary complications than those with lesser pack history. Increased mortality less than 30 days post-operatively in current smokers with an odd ratio of 1.17, but not in non or ex-smokers. So cessation of more than 4 weeks reduces post-operative complications by 23%, more than 8 weeks by 47%. And this is very important area for us as physicians, especially those doing outpatient preoperative clinics, that we have to work on this. So ex-smokers do not appear to have increased 30 days mortality regardless of their pack year history. And they defined ex-smokers who have not smoked for 1 year. So patients are 3 times more likely to remain smoke-free at 12 months if they have received intensive compared with minimal cessation support preoperatively. And this is also the area that we should be working on. So now coming to the second component of pulmonary risk assessment, which is airway assessment. So this is the area that includes identification of both difficult bag mask ventilation and intubation. So for us as physicians in the hospital setting, that may not be of importance because we have our anesthesia friend team, they're doing their own assessment. But this is of great importance in the outpatient preoperative clinic setting. So we have to, as clinicians, we have to have a system to identify patients with difficult airways and to have a system to communicate with our anesthesia and surgical team in advance so appropriate preparation can be made by assigning experienced personnel, availability of difficult intubation equipment, and most importantly, appropriate surgical location. So a scoring mechanism that is new in the past year is used to determine who is at risk of difficult bag mask ventilation is a DIF mask score. So it's a simple tally system incorporating several factors that been described in other studies as being predictive of difficult ventilation. So the authors provided sensitivity and specificity for different score cutoff to allow us to have a way to standardized approach. So there is a good systemic review published in JAMA in 2019, looked at several physical findings, increased the likelihood of difficult intubation. The best predictors were inability to bite upper lip with lower incisors, short hypomental distance, and retrognathia, or combination of several factors of Wilson's score. So the highest positive likelihood ratio came from upper lip bite test. Class 2 to 3 gave the ratio of 12 to 14, which is a pretty good high ratio. So it's an easy test to do, no much subjectivity if you teach people how to do it right. So Wilson score also have a high positive likelihood ratio of 9.1. It has the bolded items here in this table other than the upper lip bite test. Basically, it's a tool incorporating several different factors to assess for difficult intubation. So coming to the conclusion of this airway assessment, there is no single tool is perfect. Use of few simple tools with less subjectivity may improve adoption, especially by non-anesthesiology providers. We need a system in place for detection of potentially difficult airways in advance of surgery to allow an appropriate risk communication and resources planning. So now coming to the third component of the pulmonary risk assessment, which is obstructive sleep apnea risk assessment. As we know, it's very important. So obstructive sleep apnea is a common medical condition affecting 2 to 26% of general population. So studies have shown that patients with obstructive sleep apnea are known to have higher incidence of morbidity and mortality, even if they are asymptomatic. So they have increased risk of difficult intubation, postoperative complications, ICU admissions, and increased length of stay. So patients with sleep apnea have more than twice likely to develop respiratory failure, and it's estimated that 80% of men and 93% of women with moderate to severe obstructive sleep apnea are undiagnosed, and these are very high percentage. So that's why recent Canadian publication and American Society of Anesthesiologists guidelines both stressed on preoperative diagnosis of obstructive sleep apnea and perioperative management to avoid postoperative complications. So there is a study published in 2012 in British Journal of Anesthesia. Authors investigated the value of a stop-bang score in predicting obstructive sleep apnea in surgical patients. So results from 746 patients were analyzed. The odd ratio of moderate to severe obstructive sleep apnea increased with increased score. So conclusion was a stop-bang score 5 to 8 identified patients with high probability of moderate to severe obstructive sleep apnea. So that's why it's a very helpful tool for healthcare team. We can use to diagnose and stratify patients for unrecognized or undiagnosed obstructive sleep apnea to come up with better perioperative precaution measures to prevent postoperative complications. So stop-bang is a scoring model consisting of 8 easily administered questions, basically with answer yes or no. It's starting with acronym stop-bang, as you can see here. So it's basically you score 1 point for each positive response, and it ranges from 0 to 8. So now we will discuss the obstructive sleep apnea risk reduction measures. So per American Society of Anesthesiology, obstructive sleep apnea task force guidelines for patients with OSA or stop-bang more than or equal 5. Preoperatively, we should initiate CPAP, and if the patient they're not responding well, we should consider non-invasive positive pressure ventilation. I'm sorry, this is a little bit busy, but in intraoperative and postoperative obstructive sleep apnea risk reduction measures, we should consider regional anesthesia versus nerve block in superficial procedures. Spinal or epidural anesthesia should be considered in peripheral procedures. If moderate sedation is used, ventilation should be monitored with continuous capnography. General anesthesia with secure airway is preferable to deep sedation without secured airway. So unless there is contraindication, these patients should be extubated while awake. Full reversal of neuromuscular blocking drugs should be verified before extubation. Non-supine positioning head of the bed at 30 degrees if allowed by surgical restrictions, and minimize use of opioid and benzos as possible, and using non-opioid alternatives for sedation. So consider increased level of postoperative triage, so admit versus discharge, ICU versus floor, and definitely avoidance of ambulatory setting centers. So when do we refer this patient to sleep specialist, especially these patients with undiagnosed obstructive sleep apnea? I'm sorry, it's not showing well, with a stop bang score of more than 5. So we do refer them if they have uncontrolled systemic disease with pulmonary hypertension, or if they do have impaired gas exchange with refractory hypoxemia or elevated serum bicarb level. So we have a 68-year-old man with 50-pack year smoking history, hypertension, and diabetes type 2, who was recently found to have significant coronary artery disease on cath ordered after a stress test done for slowly progressing exertional dyspnea. He has been scheduled for CABG next week. His vital signs and exam within normal, including oxygen saturation of 97% at room air. His labs including cell count, renal function test, and electrolytes within normal. So question, would you obtain pulmonary function test before surgery? And I wish if you guys were here so we can enjoy the discussion. But the answer, it will be no. And we'll talk about why. So preoperative pulmonary diagnostic testing, we shouldn't order them routinely. They have very limited benefits and roles in non-lung resection surgery, including chest radiography, spirometry, and ABGs. So available guidelines, including choosing wisely for cardiac surgery from the Society of Thoracic Surgeons, recommend to obtain these studies only if otherwise being indicated, with clinical symptoms or signs of active disease, or if you know for sure that will change your treatment approach. So low preoperative SpO2 checked at supine and at room air was found to be a significant independent risk factor for postoperative pulmonary complications. Compared with SpO2 of 96%, patients with SpO2 of 91 to 95% are twice as likely to develop postoperative pulmonary complications. So those with less than 90% are 10 times more likely to develop it. So this is very simple test, comes at minimal cost, and having been externally validated and part of 2 postoperative pulmonary complications prediction models. There is a study came out just a month ago, published in International Journal of Surgery. It's a prospective cohort study for more than 600 abdominal surgery patients, looked at both clinical factors and pulmonary function test results with multivariate analysis. So these are the independent predictors after analysis, including age, operative time, blood transfusion, and vital capacity. So vital capacity or pulmonary function test came out as independent predictor. So when they looked at clinical predictors without vital capacity, the ability to predict outcome in an individual is pretty good with CStat of 0.83. So when adding vital capacity, although CStat increased somewhat, but was statistically insignificant. So to summarize, pulmonary function tests, we shouldn't be ordering them routinely unless it's clinically indicated. Patient has clinical findings suggestive of underlying lung disease should be evaluated as indicated in non-surgical setting. For some high-risk surgeries, including intrathoracic, where the result would influence management, it may be reasonable to obtain them. So several studies have shown the value of these measures in reduction of pulmonary risk, So including optimization of chronic lung disease, preoperative oral care. So we should simply tell our patients just brush your teeth and use chlorhexidine mouthwash. Preoperative inspiratory muscle training, it's very simple, early mobilization and avoidance of prophylactic NG tube unless it's really indicated. Lung expansion maneuver using incentive spirometry, it's easy. Epidural and PCA-based opioids, use regional neuraxial anesthesia versus analgesia, and proper neuromuscular blockade use, and smoking cessation. So coming now to the lung protective ventilation. So multiple studies have found an association between lower tidal volume, 6 to 8 ml per kg of predicted body weight, and decreased post-operative pulmonary complications. And these has been the standard of care. So the optimal level of PEEP and contribution of recruitment maneuvers or maneuver strategies incorporated into low tidal volume remains unclear and still remains as a question. So we have this study, ProBees, published in JAMA of 2019, basically looked at the effect of intraoperative high positive and expiratory pressure with recruitment maneuvers versus low PEEP on postoperative pulmonary complications in obese patients. So this is a randomized controlled trial of almost 2,000 patients with BMI of more than 35. They are relatively healthy, only 16% at high risk of PPCs. So they used a high level of PEEP, 12 centimeter of water, plus alveolar recruitment maneuver versus low level of PEEP of 4 centimeter of water. So all the patients, they receive a tidal volume of 7 ml per kg of predicted body weight. So what they found that there were no difference in the postoperative pulmonary complications within 5 days of surgery. But they noticed more hypotension and bradycardia in the high-level PEEP group, and this is expected with that level of PEEP. So another study came out in March 2020, published in British Journal of Anesthesia, looked at intraoperative ventilation strategies to prevent postoperative pulmonary complications. So it's a meta-analysis of 28 random controlled trials and almost 5,000 patients. So what they did, they divided RCTs. They looked at based on where they're using low PEEP, intermediate PEEP, or high PEEP, and where they're using recruitment maneuvers or not. So when you look at this, you will see compared with CMV, low tidal volume with low PEEP did not reduce pulmonary complications. But when you go higher with moderate PEEP and high PEEP, using recruitment maneuver or not, reduce the risk of postoperative pulmonary complications compared with CMV. So to summarize lung protective ventilation, Low tidal volume, 6 to 8 ml per kg of predicted body weight, is fundamental. Combination of low tidal volume and moderate to high PEEP, 5 to 8 centimeter water, with or without recruitment maneuvers, reduced risk of PPCs compared with CMV. Appropriate individualized PEEP and recruitment maneuvers may improve intraoperative ventilation and decreases PPCs when incorporated with low tidal volume. So, although there are several studies looked at different ways to reduce risks, but no specific guidelines or recommendation outlining which intervention to use in which patients. So many studies have investigated the benefit of bundles and protocols which shown good results. So ICOF bundle, which shown reduction in PPCs. In a couple of studies, it's an example of these protocols. So it's basically an acronym of incentive spirometry, cough, oral care, understand patient and family education, get out of bed, and head of the bed elevation. So another study came out in 2019 of pre- and post-operative pulmonary care bundle for non-cardiac surgery patients, decreased post-operative pulmonary complications significantly, although compliance with protocol was limited. And that's a very important point. If we start using this comprehensive bundles and protocols on everyone, some will get what they should, but we might miss high-risk patients who would have benefited the most from these protocols. That's why I'm bringing to you this study, which is basically looked at different. This is an arthroplasty study looked at different ways to reduce risks, but no specific. Yes, here this arthroplasty looked at patients, almost like more than 7,000 arthroplasty patients. It's a single center prospective study. It basically incorporated preoperative assessment process, and based on that picked on certain risk factors which triggered certain tests, and patient might be labeled at high risk. So they focused, and those patients at high risk, basically they start doing protocol for them in the preoperative time, intraoperative time, at PACU and postoperatively. And by doing this, they have noticed that the rate of postoperative pulmonary complications decreased from 5.7% to less than 0.1%. So that being said, I think this is an area we should be all working on. It's not just to identify patient or to identify risks or to assess risks, but we have to use this tool to focus our plan on high-risk patients so we know which patient we should invest time and energy on. So looking at this beautiful protocol, it's basically summing up what we have discussed earlier about pulmonary risk reduction on obstructive sleep apnea risk reduction, looking at this if this is a system we should adopt to decrease postoperative complications. So by this, I come to the conclusions of this grand round. Basically, there are many advances in perioperative pulmonary care continue to evolve as surgical populations continue to increase in age and comorbidities. Most established risk factors and risk reduction methods for PPCs continue to be affirmed by newer studies. Newer literature supports a rapidly developing role of rehabilitation and use of intuitive risk reduction measures within the context of a standardized protocol. So by this, I come to the end of my presentation. I really appreciate you guys, and you have a wonderful rest of your day. Thank you so much.